Good evening, aspirants. We shall begin the class now. The topic for today is gastroenterological emergencies and surgeries. And the speaker we have here is Dr. Deepa Gupta, who is a locum consultant in ICU at Wolford General Hospital, North London. Thank you, sir. So, you may begin.
So, good evening, everybody. Uh, Today's topic is for gastrointestinal emergencies and surgery. There are two types of questions in the EDIC-1 exam, as you all must be knowing. It's type A and type K. The type A questions are the one questions with which have five answers, and you have to choose the correct answer. While type K are the type of questions in which they have four answers and you have to answer as true and false. Okay. I'll be taking the type A questions first and then the type K. The ratio of questions in the EDIC-1 exam, it's not always fixed. Sometimes 60-40, 70-30, or 75-25. Such questions come in the EDIC-1 exam depending upon. Okay. So the first question for you all is, this is the type A question. A 55-year-old man with a history of hepatitis C, alcoholic cirrhosis, admitted to the ICU from ED with suspected upper GI bleed. He has a history of esophageal varices requiring banding in the last year. He started on PPIs and eptiotide in the ED, and gastroenterology was consulted. Soon after the arrival to the ICU, he decompensates with copious hematemesis and becomes hypotensive. The upper endoscopy for the source of control is not available for at least an hour. In addition to the continued resuscitation while awaiting gastroenterology, which of the following is the most appropriate management for this patient? The four options for this are: place a nasogastric tube, start antibiotics for SBP prophylaxis, and start a low dose beta blocker to decrease portal venous pressure. Second is to intubate the patient for the airway protection and place a Blackmore tube for hemorrhage control. Third is to place a Blackmore tube for hemorrhage control and start antibiotics for prophylaxis. Last one is to intubate for airway protection, place a Blackmore tube for hemorrhage control and start antibiotics for SBP prophylaxis. So, what do you feel is the correct answer out of this? You can answer in the chat box and then we'll discuss what exactly is the correct answer. D, someone has answered. D, anyone else want to attempt? See, what I want to say is this is not an actual exam, this is just a practice session. You should try to answer whatever you feel is correct. Even if it's wrong, there is nothing will happen. You learn from these mistakes and you will not make the same mistakes in your actual exam. Okay. B, someone has answered. No problem. Whatever you feel, you can answer, and then we'll discuss exactly what is the answer of this. Okay. So for this question, the correct answer is D. Most of you answered that correctly. It is, first you'll have to intubate the patient, place a Blackmore tube for hemorrhage control, and start antibiotics for SBP prophylaxis. So why this answer is correct? See, cirrhotic patients with esophageal varices can decompensate very quickly and require skilled resuscitation to maximize the chances of survival. This patient has sentinel bleed before ICU arrival and was started on appropriate therapy in the ED. On arrival to the ICU, the condition worsened with significant upper gastrointestinal bleeding. Airway management is very critical. Okay. So the intubation is necessary for any gastrointestinal procedure, as in placing a Blackmore tube. So the Sengstack Blackmore tube is just a rescue measure and it can be done uh, only after intubating the patient. You cannot just put this tube without intubating. So the intubation to be made and then Blackmore tube in the esophagus is to be inserted. Often overlooked for critical to improved outcomes in and is antibiotic prophylaxis to prevent the SBP in cirrhotic patients with variceal hemorrhages. Starting a third generation IV cephalosporin has been shown to reduce all cause mortality, infection related mortality, rebleeding events, and hospitalization lengths of stay. So the third most important part of this question was the antibiotic, which has to be started even if you don't suspect an infection, because there may be an infection and it may be an SBP. Okay. Inserting a nasogastric tube is not incorrect because it has never been shown to worsen the varicose bleeding, but starting a beta blocker in this acute setting in hypotension is incorrect because it may worsen hemodynamics. So the best option and the best answer was D for this question. We'll move on to the next. Just wanted to share one article with you. It is a practice guidelines for the diagnosis and treatment of alcoholic liver diseases 2019 by the American Association for the Study of Liver Diseases. You can find this on net. If you would read, it's a very nice guidelines given for this. Okay. Second question. This is a 38-year-old woman at 34 weeks gestation admitted to the ICU with altered mental status and jaundice. Right upper quadrant ultrasound reveals a fatty liver. Which of the following is the most appropriate therapeutic intervention? You can answer in the chat box. If you know what the problem this patient is facing, you will be able to answer it. Pregnancy with mental status, altered mental status, jaundice, and right upper quadrant pain. Anyone? Yeah, yeah. Correct, correct. Yeah, most of you got this correct. The option D is correct. That is the delivery of the fetus. Let's see why this option is correct. So, exact diagnosis in this case is acute fatty liver of pregnancy. It is a life-threatening condition occurring in the last trimester. Differentiation from the HELP syndrome and severe preeclampsia may require a liver biopsy, but acute fatty liver of pregnancy is associated with hepatic dysfunction, including the synthetic function. Ammonia and transaminases levels are higher. Hypoglycemia is more frequent and disseminated intravascular coagulation is common. The treatment of choice for this is delivery of the fetus and supportive care. So this was the correct answer. It's a 34 weeks gestation. You have to do the delivery of the fetus in this case. Okay. We'll move on to the next question. This is a 41-year-old female which presents with abdominal pain, nausea, vomiting, and diarrhea. Examination shows her to be mildly jaundiced in AF and agitated with bibasal crackles on chest auscultation and peripheral edema. Observation include heart rate 134, BP 76 by 45, respiratory rate 28, saturation 93% on room air, and temperature 39.6. She has mildly deranged liver function tests, a normal white cell count, CRP. A beta HCG test suggests she is pregnant. What is the most likely diagnosis? Yeah, can you answer this? The options are thyroid storm, decompensated alcoholic liver disease, sepsis, malaria, ectopic pregnancy. Very clear cut clues given in the question. If you catch those clues, you can get the answer in this. Second question again on pregnancy. Anyone wants, they can answer in the chat box. See, even if it's wrong, don't worry about this. You should at least attempt. Okay, see, someone has answered E, someone has answered D. Okay, let's see what the correct answer is. The correct answer for this question is A. A. It is what is? It is a thyroid storm. It is very common in pregnancy, and many clues were given: high temperature, tachycardia, hypotension, high respiratory rate. We'll see what is it. See, the combination of symptoms seen in this patient is highly suggestive of thyroid storm. Pyrexia is not generally a feature of decompensated alcoholic liver disease, and sepsis is unlikely given the normal WBC and inflammatory markers. Patient with malaria usually presents with fever, headache, malaise, and gastrointestinal jaundice, and respiratory symptoms can be seen. However, tachyarrhythmias and cardiac failures are not normally present. So the other things are ruled out, and the most probable diagnosis in this case is thyroid storm. So thyroid storm, it is explained everything over here. It is difficult for me to complete the 25 MCQs and explain each and everything. So I think thyroid storm, you can read from most of the textbooks or the explanation given over here afterwards. I'll not go into the detail of it, or will not be able to complete even 10 or 15 MCQs within an hour. Okay, so you just read it, but this type of questions will come in the exam. We'll move on to the next question. You are asked to admit a 48-year-old female with acute on chronic liver disease and grade 3 encephalopathy. She has been admitted under the medical team with acute kidney injury and deteriorating liver function tests. There is no clear precipitant for the decompensation of history from the family. They also state that she continues to drink heavily. On review, she has a normal oxygen saturation on FiO2 of zero point 0.4 with a PO2 of 10 kilopascals. She is hypotensive 76 by 40 and tachycardic 110 beats per minute. The catheter in situ, and she has passed 20 mLs of urine over the last 8 hours. Her bilirubin is to 30 millimoles per liter and alanine transaminase is 56, creatinine is 478. Which of the following prognostic systems is likely to be the best predictor of outcome in this patient? So the options are MELD score, Child-Pugh score, Apache 2 score, SOFA score, or Glasgow Coma score. Now, see few important tips regarding solving questions in EDIC 1. Okay, someone has answered. I think A, someone has answered MELD score. Okay, MELD score. Okay, okay. Few general tips regarding solving questions in EDIC 1 exam. The first thing what I wanted to tell you is, could you see how I was reading the question? So in most of the questions, the EDIC 1, they give a very big story. It's a very long question. You have to have the practice from today itself. You try to read the question very quickly, because if you go on reading very slowly, like you are asked to admit 48-year-old female patient acute on, it will waste your time. Most of the things are big questions are given to just waste your time so that you are unable to complete the paper. You have to make a practice to read the questions clear, fast, and just grab the important points which are there. Other thing is like what I read on review, she has a normal oxygen saturation FiO2 0.4, hypotensive. Just don't read she is hypotensive. Just BP you can see, heart rate you can see, and oxygenation you can see. So make a habit of reading fast the questions so that you can save time and you can complete the paper. Stories are given just to waste your time. Okay, so in this question, the could and the most important of the whole story is the last line. What is the last line? Which of the following prognostic systems is likely to be best predictor of outcome of this patient? So it is not asking you about the liver. They are asking how would you prognosticate the patient. It's about prognostication. The word prognostication is very important. Exactly. Few of them have got this correctly now. MELD score, Child-Pugh score, they will tell us about the present liver condition. But the correct answer for this D, it is the SOFA score. Why? It will
क्या
help you in the
देखते
prognostication.
हैं ना
Okay. Sorry, anyone has to say something? Okay, okay. Maybe by mistake the mic was turned on. No problem with that. Okay, so the correct answer is D. It's the SOFA score. Why we'll see this answer is correct. So this patient unfortunately appears to have a multiple organ dysfunction. There is neurological, hepatological, cardiovascular, or renal involvement. Prognosis in this situation, especially in the absence of reversible precipitant, would be very bleak. Recent data would suggest the following: three organ failures and mortality about 90 to 100%. Interestingly enough, the generic organ failure scores appears to perform better on predicting outcome than specific liver disease scoring systems. Are you able to understand what exactly they were trying to ask? They are not asking only specifically about the liver disease scoring system. It's like a multiple organ dysfunction happened over, and four of the organs are involved. At the recent systematic review, the SOFA score performed best with an area under the receiver operating curve. AUC is more than zero point 0.9 with reporting excellent discrimination. In contrast, Child-Pugh score demonstrate AUC of 0.6, 0.7 and MELD score around zero point 0.8. As such, if you were seeking to discriminate likely survival, the SOFA score would be the best choice to guide the clinical decision making in an acute situation. So the SOFA score was the correct answer. Okay, let's move forward. Let's see the next question. Now, this is a 71-year-old woman admitted in the hospital with diarrhea, having discharged from hospital 15 days prior following treatment with metronidazole for C. difficile. Past medical history includes hypertension, IHD, diabetes. She also had CD at 3 months previously, treated with metronidazole. She is having 5 to 7 stools per day, which is positive for C. difficile infection. Investigation showed heart rate 95, BP 108 by 76, 38 degrees centigrade, creatinine 94, WBC 12 in 12,000, most appropriate therapies. Oral metronidazole, vancomycin, fecal transplantation, fidaxomicin, oral rifampicin 300 milligram. So, a few tips regarding this question. First thing is C. difficile, one of the very favorite topics of EDIC 1 examiners. Mostly out of 100, one or two questions definitely you will get on C. difficile infection. It's one of the favorite topics of EDIC examiners. So they put a question on this. And you should be very thorough regarding the treatment of C. difficile, regarding which is the treatment in the first case, first, which is the treatment in recurrent cases, and which is the treatment in refractory cases, what are the last resort for C. difficile. Okay, not very common in India. We don't treat so much, so we don't have much knowledge. But theoretically, you should be very clear regarding this, because here in UK, it's very common, and every diarrhea patient in our ICU, what we get, has to be investigated for C. difficile infection. Okay, so very important topic. You should be thorough. Okay, someone has answered correctly. Yes, I think most of you have got this correctly. Its answer is D, that is the oral fidaxomicin. It's 200 milligram BD is the dose. So answer is D. This patient has got recurrent CDI, because see, there was given it was previous also. Therefore, this current infection should be treated with fidaxomicin to decrease the risk of further recurrences. Severe cases not responding to oral vancomycin should be treated with high dose oral vancomycins and IV metronidazole. Oral rifampicin and intravenous immunoglobulins can be used, but there is no evidence to support the use of this agent. Fidaxomicin, regarding it, its complete explanation is given. You can read it anywhere in the books, it is given. And last resort is fecal transplantation, rarely has adverse effects and causes resolution in 81% of the patients. Okay, so you go home and read this topic C. difficile. One thing I just wanted to say is new guidelines of C. difficile has come up in the recent years. The old guidelines have been changed. So the EDIC 1 people focus whether you know the newer guidelines or not. So this is just a screenshot I have taken from the newer guidelines. On the net you go, you will get the recent treatment of C. difficile infection, and just read it and be thorough with it. Okay. You can read, this is a 2021 guidelines given by IDSA, which are the which will explain very nicely the C. difficile infection. But the treatment which has changed recently, you need to go through the recent treatment last year which they have changed. Okay. Now, regarding penetrating abdominal injury, the following are true except the most common cause of death in the first 24 hours is hemorrhage. Peritonitis is in a hemodynamically stable patient is an indication for laparotomy. Most commonly injured organ in penetrating stab wounds is the liver. Chest X-ray is an insensitive test for diaphragmatic injury, and a negative fast scan has a high negative predictive value for injury requiring laparotomy. So another tip I want to give in this question is just read this regarding penetrating abdomen. The following are true except. Okay. They could have written in this the following statement is false, but usually this is a very common thing in edic exams. They write this true except. If you don't read the question carefully, that true except, if you find a true question and you mark and go ahead, it will be wrong. So concentrate too much on every word which is given in the question.
Yes,
Okay.
Birbal.
So what is the correct answer? You can answer in the chat box. Which is the, what they are asking is, which is the false one out of the five? Which is the false statement regarding penetrating abdominal injury? Anyone would like to attempt this? Okay, I think yeah, few people have tried to attempt E. Okay, let's see what the correct answer is. Okay, the correct answer is E. Both of you answered this correctly. So, a penetrating abdominal injury may cause injury to vascular structure, solid organs, or a hollow viscus. Peritonitis may reflect leakage of digestive tract contents from a hollow viscus and is an indication for laparotomy. Most commonly injured organs, the first one is 40% liver, small bowel 30, diaphragm 20, and colon 15%. Chest X-ray is a relatively specific for diagnostic injury with an abdominal stab wound, although low in sensitivity. Abdominal CT is the investigation of choice for assessment of injury to the liver, spleen, but lacks sensitivity for detection of the mesenteric, hollow viscerus, and diaphragmatic injuries. Negative fast scan has a negative predictive value for laparotomy of only 60%. It may miss the free intraperitoneal blood and will not reliably identify injuries to structures such as diaphragm and bowel, which requires operative repair. Okay, so E was the correct answer in this question, which was a fast scan is high negative predictive value for injury requiring laparotomy. Now,